Arunima Sensei, it's
Yes.
time to start.
Yes. Good morning. Today, our session is on medical education. I am the first presenter. I am Arunima Chaudhuri from Bardwan Medical College. Academic leadership in medical education, navigating challenges and fostering innovation. Medical education is undergoing profound transformations in response to societal, technological, and healthcare advancements. The role of academic leadership in medical education is many, and innovative approaches need to be adapted to meet the demands of the evolving landscape. Curriculum development and adaptation. Medical education curriculums need constant adaptation to align with evolving medical knowledge, healthcare systems, and societal needs. Leaders play a crucial role in driving this continuous assessment, update, and innovation. Faculty engagement and development. Effective medical education leadership goes beyond administration, focusing on fostering a culture of continuous faculty learning and development through mentorship, professional opportunities, and addressing burnout. Technological integration in medical education. Medical education leaders need to effectively integrate digital tools, simulations, and online learning platforms into curriculums while bringing the digital divide and ensuring accessibility for all students, diversity, equity, and inclusion. Leadership plays a crucial role in promoting diversity and inclusion by actively recruiting and retaining a student body and faculty that reflects the broader society and addresses existing healthcare disparities, leadership styles, and their impact. Effective medical education leadership requires understanding different leadership styles like adaptive, transformational, distributive, to cultivate a culture of innovation, collaboration, and continuous innovation within the medical institution. Organizational leadership refers to the management and direction provided by institutions such as medical schools and colleges, teaching hospitals, and healthcare systems. Key aspects: vision and strategy, resource allocation, curriculum design and assessment, faculty development, collaboration, partnerships, and quality improvement. Individual leadership refers to the actions and behaviors of educators, clinicians, learners within the medical education systems. Key aspects: teaching excellence, mentorship and advising, innovation and scholarship, interprofessional collaboration, advocacy and social responsibility, and lifelong learning. Academic leadership in medical education is a dynamic and multifaceted role that requires a blend of administrative acumen, visionary thinking, and deep commitment to educational excellence. As the landscape of healthcare and education continues to evolve, academic leaders must remain adaptable and innovative, shaping the future of medical education to produce competent and compassionate healthcare professionals. Now let us see the differences between a manager and academic leader. Manager focus and goals focuses on achieving specific organizational goals such as maximizing efficiency, meeting targets, and ensuring smooth operation within a defined structure. While academic leader focuses on guiding academic endeavors such as research, teaching, scholarship, they may prioritize fostering intellectual growth, innovation, and academic excellence. Nature of work: managers, decision-making related to resource allocation, personnel management, and strategic planning to meet organizational objectives. For academic leaders, it is curriculum development, monitoring faculty and students, promoting research initiatives, and fostering a culture of academic integrity and excellence. Authority and influence: manager has formal authority over subordinates and is responsible for directing their works to achieve organizational objectives, while academic leaders exert influence through expertise, mentorship, and collaboration, rather than direct authority. Performance metrics. For manager, it is evaluated based on metrics like profitability, efficiency, customer satisfactions, and adherence to deadline. For academic leaders, evaluated based on criteria such as academic publication, research impact, teaching effectiveness, mentorship, and contributions to the academic community. In organizational context, manager operates within a corporate or business setting where the primary focus is often on financial performance and market competitiveness, while academic leader operates within an educational institution where emphasis is on advancing knowledge, fostering critical thinking, and preparing students for academic and professional success. Stakeholder relationship. Managers often interact with stakeholders like customers, investors, suppliers, and regulators, while academic leaders engages with stakeholders like students, faculty, administration, funding agencies, and the broader academic community to support educational and research missions. While there are differences between the roles of manager and an academic leader, it's worth noting that individuals in either role may possess qualities that are beneficial in both contexts, such as effective communication skill, strategic thinking, and the ability to inspire and motivate others. Academic leadership and change management in medical education. Medical education is undergoing a transformative phase driven by advancement in technology, shifting healthcare paradigms, and the recognition of the need for more patient-centered and outcome-oriented approaches. So, foundations of change management in medical education: leadership and vision, stakeholder engagement, curriculum design, and integration, technological integration. Now, there are some challenges. Resistance to change. Faculty and students may be apprehensive. Addressing this resistance involves transparent communication, training programs, and highlighting the benefits of the proposed changes. Resource constraints. They may be financial and human. Strategic allocation of resources, seeking external collaboration, and leveraging technology can help to overcome these constraints. Regulatory compliance. Adherence to accreditation standards and regulatory requirements is paramount in medical education. Change initiative must align with these standards, and collaboration with accrediting bodies is essential to ensure compliance. Success stories. The competency-based medical education has been implemented in India in 2019, and all institutions are managing it effectively. Interprofessional education. Embracing interprofessional education fosters collaboration among healthcare disciplines. Institutions that successfully integrate interprofessional education into their curricula report improved communication skill among students and a more holistic approach to patient care. Transformational leadership in medical education. Transformational leadership is characterized by a forward-thinking, collaborative, and adaptive approach. Key aspects are visionary leadership, innovation and adaptability, collaboration and interdisciplinary approaches, student-centered focus, continuous improvement, cultural competence and diversity, ethical leadership, communication skills, adaptive leadership, research and evidence-based practices. Now let us see about the key aspects of leadership in medical education. Effective leadership in this context involves guiding and inspiring educators, fostering a positive learning environment, and shaping the future of medical education. Vision and strategy. Leaders in medical education should have a clear vision for the future of the healthcare education. Curriculum development. Leaders should ensure that the curriculum is well balanced, integrates new teaching methods, and addresses the evolving needs of healthcare system. Innovative teaching methods. Leaders should be open to adopting new educational technologies that can enhance the learning experience. Faculty development is essential. Assessment and evaluation. Regularly reviewing and updating assessment methods can help identify areas for improvement and ensure that students are meeting the necessary competency standards. Interprofessional educations. Leaders should support initiatives that encourage interprofessional education to prepare the student for teamwork in real-world healthcare settings. Ethical and professional development, adaptability and flexibility. Flexibility in responding to emerging trends and challenges ensures that medical education remains relevant and effective. Research and scholarship and advocacy. This involves promoting the importance of education in producing competent and compassionate healthcare professionals. Now, leadership styles in medical education. Transformational leadership. Transformational leaders often focus on improving the quality of education, promoting research, and enhancing the overall academic environment. Transactional leaders use structured system for evaluating faculty performance, implementing incentive programs, and ensuring adherence to established educational standards. Servant leadership focuses on supporting faculty, staff, and fostering a positive learning environment and addressing the diverse needs of student trainees. Collaborative leadership. These leaders work closely with faculty, students, administrators, and other stakeholders to develop and implement educational policies and initiatives. Authentic leadership prioritize open communication, ethical decision-making, and creating a culture of trust and integrity. Innovative leadership explore and implement new approaches to teaching and learning and incorporating technology, simulation, and other advancements. Laissez-faire leadership provides autonomy and independence, encourages critical thinking, creativity, innovation, and adaptability. The leadership styles of academic leaders significantly influence the culture and outcomes of medical education. A balance between different leadership styles, depending on the context and needs of the institution, is often ideal for fostering a dynamic and effective learning environment. Effective leaders often employ a combination of styles, adapting to different situations to maximize positive outcomes for medical education. Now we have seen about the different leadership styles. Let us see about their negative effect. For transformational leadership, it can be more of a dependency on the leader. For transactional leadership, there may be risk of rigidity and limited motivation, laissez-faire, lack of direction, and potential of disorganization. For servant leadership, there may be problem in decision making. Authoritative, there may be stiffened creativity. Key areas to focus on for the development of academic skills, leadership skills, that is strategic vision and planning, strategic thinking and decision-making skills, effective communication, communication skills and listening skills, team building and collaboration, team leadership and conflict resolution, educational innovation, curriculum development and technology integration, research and scholarship, promoting research and culture, publication and dissemination, advocacy, and institutional leadership, advocacy of medical education and mentorship. Other areas are continuous professional development, ethical leadership, and professionalism. Some strategies for medical educators to help students build leadership skills: incorporate leadership training in the curriculum, encourage active participation in extracurricular activities, mentorship programs, leadership workshops and seminars, promote self-reflection, team-based learning, emphasize emotional intelligence, expose students to diverse leadership styles, encourage research and quality improvement projects, provide leadership opportunities in clinical settings. So there are different factors. Example, technological integration, interdisciplinary collaboration, globalization of medical education, lifelong learning, and continuous professional development. Emphasis on well-being and resilience, diversity, equity, and inclusion, regulatory and accreditation changes, data-driven decision making. We need strategic planning, that is, setting clear goals and objectives, resource allocation, adaptation to change, enhancing collaboration and communication, improving performance and accountability, promoting innovation and excellence, managing change, building a stronger reputation. So, in conclusion, effective leadership in medical education requires a combination of strategic vision, collaboration, innovation, and a commitment to excellence in teaching, research, and clinical practice. The understanding and application of several leadership philosophies should be included in leadership education. Thank you. Over to Dr. Aarti for her presentation. Dr. Aarti is from Haryana, India. She is professor in Department of Anatomy. Over to Aarti, madam, for your presentation.
Is my screen visible, ma'am?
Yes, visible. There is a black box appearing at the top.
Yes, ma'am. Just hiding that. Thank you, Dr. Arunima. It will go.
Madam, okay. Okay, now it is okay. Go ahead, ma'am. Thank you.
Thank you, Dr. Arunima, for such a lucid presentation and also providing me the opportunity to be the part of this group. The topic for my presentation is application of solo taxonomy in anatomy education. So what is taxonomy? Taxonomy is the word derived from word taxus, which means arrangement, and nomos means law or science. It is the practice and science of classification. It involves the arrangement of various entities into categories or groups based on shared characteristics. Taxonomies we have learned from class 12th in biology, and now we are, as mentors, we are practicing the educational taxonomies. Educational taxonomy is the framework for categorizing educational goals, objectives, and standards. It helps to design curriculum, assessment, and instructional methods. It is basically a framework which helps us to implement the educational process in a better way. So when we are teaching the students, we have to work upon the various levels of thinkings of the student. And we all know not all the thinking and knowing of the student is same. And maximum of the students, when we ask questions from them, they reply with the help of either the recall or just remembering the things up. If we can develop students' higher order thinking skills, this will enhance their metacognitive abilities and hence their learning. So we predominantly, we have two taxonomies available, and most commonly used taxonomy is the Bloom's taxonomy, which classifies educational objectives into cognitive, affective, and psychomotor domains that we are all well aware of. Then we have solo taxonomy. It describes the level of increasing complexity in students' understanding of subjects. So we can see two taxonomies which are more or less comparable. One works with educational objectives, one more or less works on assessment. So Bloom's taxonomy is in the form of a pyramid, and at the base of pyramid, we have lower order thinking skills. As we move up, we are moving towards higher order thinking skills of analyzing, evaluating, and creating. Elaborating the solo taxonomy, solo stands for Structure of Observed Learning Outcomes. It is proposed by John B. Briggs and Kevin F. Collins in 1982. The solo taxonomy model classifies learning outcomes in terms of their complexity, enabling us to assess students' work in terms of its quality, not on how many bits of this and that they have got right. The major lacuna in Bloom's taxonomy, and there is another approach that is called as Gagnet's hierarchy, both of them represent the logical analysis of content and process of teaching learning. It does not help in assessing the sophistication of learning outcomes. So in 1982, this is the book written by Biggs and Collins, which is towards a model of school-based curriculum development and assessment using Solo taxonomy. It was initiated in for school teaching, but now in medical education, we are trying to adopt this. He has described the 5 stages of Solo taxonomy, that is pre-structural, unistructural, multistructural, relational, and extended abstract, depending upon the cognitive activity and degree of complexity of the outcome. And it has also described the difference in the surface learning and deep learning. In pre-structural, this is the first stage where the students do not have any knowledge or understanding of the topic being studied. A student who is pre-structural will usually respond with, I don't understand, or I'm not sure about. If we give them the question, probably they have no answer to that question, or they ask us to repeat the question, or they provide the wrong answer. In unistructural level, students have the limited knowledge of the topic. They may just know one isolated fact about the topic. So a typical response could be, I have some understanding of the topic, or I have one relevant idea about. And they may give the answer in the form of short answer, or students just only understand only one relation. In multistructural, the student knows a few facts about this topic, which enables them to link together. For example, if we see these all pins, if it would have been a single all pin, it would be unistructural. Now the multiple all pins are being connected with the help of threads. So linking has started. The students respond, I know a few things about this topic. I have gathered some information about this topic, but they do not have the holistic view. So this is the level of surface learning. When we proceed further, that is at the relational level, what we are starting to move towards high level thinking. So over here, the students now have a bigger picture of pins joined with the help of threads. Now the students are able to link together and explain several ideas around a related topic. And they have a connection between the information that they have gathered, and they can link them to the big picture. In the extended abstract, it is a complex level. Not only the students able to link the lots of related videos together or the facts together, but they link these to other bigger ideas and concepts. For example, this is the picture again drawn with the help of pins and threads interconnecting, but this is the creation of the students. So by reflecting and evaluating on my learning, I'm able to look at the bigger picture and link lots of different ideas together. So this is the highest level of Solo. Solo has primarily been used in assessment, but Solo can not only be used in assessment, but it can be used in designing the curriculum in terms of level of learning outcomes intended, which is helpful in implementing the constructive alignment between the learning objectives, learning activities, and the assessment. As we all know, learning objectives, TLMs and assessments, they are all linked together. Now, why to use Solo when we have Bloom's? Solo is actually a true hierarchic taxonomy, which increases in quantity and quality of the thoughts. It is a powerful tool in differentiating curriculum and providing cognitive challenge for the learners. And it allows both the teachers and learners to ask deeper questions without creating new superficial questions. And so it is a powerful metacognitive tool. So it has differentiated between surface and deep thinking. Unistructural and multistructural questions test the student's surface thinking, that is lower order thinking skills. Relational and extended abstract questions, they test deep thinking, that is higher order thinking skill. So use of Solo allows us to balance the cognitive demand of the questions we ask and to scaffold students into deeper thinking and metacognition. Solo taxonomy can be implemented in various ways to enhance the learning outcomes. For example, in curriculum designing, teaching strategies, assessment, feedback and reflection, and its integration with technology. How it can help in curriculum design. If we talk about anatomy education, which is the basic subject for all the medical curricula for the undergraduates, anatomy courses can be structured to progress through the levels of solo taxonomy. For example, basic anatomical structure and concepts can be introduced at pre-structural and unistructural levels, and deeper understanding and integration of concepts it occur at multistructural, relational, and extended abstract levels. And if we implement solo taxonomy for teaching strategies, so we can employ teaching strategies that align with each level of solo taxonomy. For example, lectures and demonstration may target pre-structural and unistructural understanding where we give the students the facts. Then integration with the help of case-based learning, problem-solving activities, and group discussions can foster relational and extended abstract understanding of the subject. Now, feedback, reflection, and solo, how can be interrelated? Feedback and reflection, they play important roles in learning. Encouraging students to reflect on their learning experiences and identify areas for improvement, it can facilitate deeper understanding and again, metacognitive development. And now we are in the Gen Z where technology is prevailing. So using digital tools and resources such as virtual anatomy softwares and interactive simulations can improvise anatomy education. And when integrated into learning activities aligned with solo taxonomy, these technologies allow the students to explore anatomical structures and functions at different levels of complexity. And integration with technology opens up exciting possibilities for interactive and engaging learning experiences. And this technology and innovations will be discussed by Dr. Kamal Singh in the last presentation. The various strategies which can be followed for implementing are practice testing, distributed practice, and successive learning. Practice testing involves non-summative assessments, like we give flashcards and practice questions to facilitate retrieval of information. For example, fill in the blanks, short answer, multiple choice questions. But they are usually at the pre-structural and unistructural level if the questions are simple. Distributed practice, in this, instead of cramming the information into a single study session, this technique involves spreading out learning over time, either within a single session or across the multiple sessions. This method enhances the long-term retention. For example, usually what we do is we keep on sitting for long hours for learning and then we remain free. So free time and learning time, they are more or less separate. But spacing the learning and free time together. In one phase learning, then some time free, then learning, then some time free. So this spaced practice or superior spaced practice helps better in long-term retention. Similarly, successive relearning. This strategy combines practice testing and distributed practice, and students can use practice questions repeatedly until they can answer them all correctly on the basis of solo levels. This iterative process reinforces learning and improves retention. So there have been arguments against ineffective methods like rereading text, which does not lead to robust learning, and solo is totally against it. Instead, it advocates for evidence-based strategies to make learning more efficient and effective for medical students. So by implementing these techniques, students can enhance their understanding and retention of clinical anatomy and other science subjects. Now, how solo can help in assessment designing? For example, the questions and tasks can be designed for each solo level. For unistructural level, we can have simple questions. For extended abstract level, we can have case scenario based questions. And rubrics can be designed for assessment so that assessment is uniform. And it helps in demonstrating the student progression. Through the levels of solo taxonomy, students progress from identifying individual components, and this structure approach helps in developing a deeper and more integrated understanding of anatomy. Various challenges and solutions for implementing solo. Implementation of solo taxonomy is a time-consuming process. So we need a team to build that. So we need to provide professional development sessions. And how can we provide the professional development sessions? Again, it is we have to provide the training, and this is again a challenge. So faculty development programs can be a solution to it. Then maintaining consistency in application of solo taxonomy across different courses and assessment is a big challenge. The solution could be developing standardized rubrics and guidelines to ensure uniformity in assessment practices. And students may initially struggle to understand different levels of solo. So we need to provide them clear explanation and examples into the curriculum to help better grasp the concepts. So benefits of solo are improving the learning outcomes of the students, and for teachers also, it helps in enhanced teaching practices for improved student engagement and success. It helps in enhanced understanding. It encourages the students to think critically and make connections. And similarly, it helps in improvement of assessment, providing a clear framework for evaluating student learning. In conclusion, employing solo taxonomy in anatomy education not only enhances the depth and coherence of students' learning, but also equips them with a structured framework for critical thinking and integrated learning. So, going solo can help prepare a better team for healthcare. Go solo, go far. Thank you so much.
Thank you, Arati Madam, for your wonderful presentation. Over to Professor Ashitab Debray for his presentation. Ashitab sir, over to you.
Yes, madam. Am I audible?
Yes, audible and visible.
Okay. So at the very outset, I thank you, Arunima madam, for giving me this opportunity. I also thank the APAN team for giving me this opportunity. Good morning, everyone. So we are very familiar with this pyramid, which is called the Miller's pyramid. And when we talk about teaching our students, we teach the when they learn. So they learn from this very base of the pyramid. They learn first. When they learn, they know, and then they start knowing how to apply. So they know how, and then they start applying their knowledge. So they show, and finally they perform. They do. Now this Miller's pyramid has been amended, and we have seen that at the peak of the pyramid, there lies their identity, where they have to demonstrate their attitude, their values, their behaviors, which is expected of a physician. And with this background, my topic today is, when we are teaching pathology to undergraduate medical students, are we doing justice as per this Miller's pyramid? Now, why do we teach pathology to undergraduates? Usually, what is the purpose of teaching pathology to undergraduates? To make them learn and understand the pathogenesis of a disease, to enable them to approach a disease with respect to its clinical spectrum, to form the basic foundation for them to become good clinicians who are able to order appropriate tests, and not only order appropriate tests, but also interpret the results which they have ordered. Now, what is the context of today's presentation? Now, we have seen that pathology has been taught in a very traditional way since time immemorial to the undergraduate medical students in India. Therefore, majority of the medical graduates, they end up having very little understanding of what investigations to order for which disease and how they should be interpreted. Ultimately, they forfeit the purpose of undergraduate pathology teaching. The same is the case with assessment in pathology for these undergraduate medical students. And ultimately, what happens is the students' learning tends to get restricted to the lower levels of Miller's pyramid, the Miller's pyramid that we have just seen. So it gets restricted to the lower levels up to knows, or probably up to knows how. And also the lower hierarchical levels of cognitive domain of Bloom's taxonomy that we also know, predominantly up to the remember or understand or barely apply. Now, what we do usually, what we are usually doing when we are teaching pathology, we majorly focus on teaching the pathogenesis of the disease, the gross and microscopic morphology, and some laboratory tests which are obsolete at present with very little clinical presentation or correlation. Assessment till recent past, I mean, in 2019, the competency-based curriculum was introduced. Before that, and also we have seen that also we are trying hard to implement CBME. Still then, The assessment has been subjective, non-structured, and with little scope of judging clinical application and higher order analytical skills. The teaching learning methods usually which are adopted are didactic lectures, practicals and demonstrations, and also tutorials. And assessment methods usually include long answer type questions, short answer type questions, and multiple choice questions for theory, and exercise and viva voce for practical examination. Then what can be done? So we are talking about incorporating trying to teach the students in a way that they learn pathology with a clinical correlation. So what can be done to improvise? So the subject of pathology, it covers a wide variety of disorders and diagnostic tests, only a portion of which is taught to undergraduate students. So we know that pathology is a very vast subject. We cannot cover it in the undergraduate curriculum. So only a portion of which is taught to undergraduate. And therefore, since we are only teaching a portion of it, it is preferable that we begin teaching the most useful and the clinically applicable topics, which will help them to correlate clinically. So it is always better that we teach them with the help of cases, with the help of scenarios, so that it makes the students understand the subject better. So such case-based learning and problem-based learning promote a learner-centered exploration of cases, which in turn helps the students in developing their logical and analytical skills, and also help them acquire the required skills of attitude, ethics, and communication as per the module of National Medical Commission. Now let us look at an example of a case-based learning. So usually this is how we go for teaching the students of pathology with a case-based learning module. So 25-year-old male presents with redness, swelling, and pain in his right lower leg after sustaining a cut while playing soccer for 2 days. The patient noticed the area around the cut becoming progressively redder and more swollen. Pain has increased over the past 24 hours. He has mild fever, no significant past medical history. On physical examination, the vital signs showed temperature 38 degrees centigrade, heart rate 90 beats per minute, blood pressure 120/80 millimeter of mercury. Local examination reveals erythematous, swollen, warm, and tender area around a 2-centimeter laceration on the lower leg, and there is purulent discharge from the wound. Laboratory findings showed CBC, leukocytosis with predominance of neutrophils, elevated CRP, and erythrocyte sedimentation rate. Now, the related questions for this case we can keep as: what is the cause of redness, pain, and swelling in this case? Discuss the pathophysiological mechanisms underlying these signs. What is the cause of purulent discharge? Explain the cause of leukocytosis and raised CRP in this case, and the treatment principles for acute inflammation. Now, see, instead of teaching the students the topic of acute inflammation in a very conventional way, what we do, we try and teach them the definition of inflammation, the cardinal signs of inflammation, what is pus, and what is the mechanism of formation of pus. Instead of doing that conventionally, what we do is we put them a case, and we try and we try to give the students a case which they explore, and we put some questions along with it so that they can analyze the case and come out with the answers of those questions related to the case. That way, that will help them to enhance their higher order analytical skills, critical thinking skills. Now, what can be done for assessment? Now, assessment at the same time must be more structured. It has to be objective, clinical oriented, and should be able to judge the analytical skills. So only teaching them would not help. So always we have to assess what we are teaching. So the assessment at the same time should be, clinically oriented. So introduction of seminars, poster case presentations, quizzes for formative assessments, and objective structured practical examination or objective structured viva, problem-based questions for summative assessments will help both the students and faculty in achieving the desired goal. So this is again an example of case-based learning. What we do is we put a picture, or we actually give a slide, histopathological slide to the students, and we give a question or a case along with it. Well, like a 20-year-old male visited the clinic with complaints of lump in his neck for 2 months, along with low-grade fever, malaise, and loss of appetite. A biopsy of the lymph node was taken. Carefully examine the given slide and answer the following questions. Identify the pathological condition. What is the mechanism of cell injury for the above condition? What are the other patterns of this type of tissue injury? What are the different patterns of nuclear changes seen in this type of cell injury? So basically, what we can see is gross necrosis out here. So rather than teaching them what is necrosis, types of necrosis, theoretically, if we show them a slide of necrosis like this, this is basically a slide of caseous necrosis in a typical case of tuberculosis. So tuberculosis is very common in India. And if we show them a slide of tuberculosis, a case of caseous necrosis, so it is very easy for them to learn, clinically correlate, because when they become clinicians, it is very easy for them to correlate this learning of pathology when they're going to treat their patients. So next question is, do we need to teach communication skills in pathology? So usually it is like, we always think that it is the clinicians who always need to communicate with the patients, with the patient party. But then gone are the days when pathologists used to sit behind closed doors with their eyes glued to their microscopes, or even sometimes with their reference books, with little or no interaction with patients. Nowadays, pathologists are expected to have effective communication not only with the clinicians, but also with the patients. Now, although this may be an eyebrow raiser for many of us who think that it is only the clinician's prerogative to interact with the patients, but it is the truth. Most of the time, the test requisitions are not accompanied with a proper clinical and therapeutic history of the patient. And in these situations, it is always better to have a word with the patient himself regarding the relevant history in order to correlate with the results which we sign out. So, Terry Canal, in his vice presidential address at American Academy of Orthopedic Surgeons, rightly mentioned that the patient will never care how much you know until they know how much you care. So if we do not teach our students the skills of communications in the domain of pathology, so the teaching of pathology remains incomplete. So again, a 68-year-old person complaining of pain on the right side of upper abdomen was diagnosed as a case of acute on chronic cholecystitis clinically and on upper abdomen USG. After initial conservative treatment, he was taken up for surgery and a laparoscopic cholecystectomy was done. The resected gallbladder was received in pathology, processed as per standard protocols, and was reported as adenocarcinoma gallbladder PT2N1M0. What does the patient understand or interpret? Now, when the patient is given a report like this, adenocarcinoma gallbladder PT2N1M0, and the patient would collect, it is always saying that the patient comes to collect the histopathology report from the pathologist, and the patient is in a dismay. He or she is in an apprehension as what is written in the report. Now, as pathologists, we should come forward and talk to them, speak to them, and explain what is written in the report. And this is where the art of breaking a bad news comes in. So we also have to teach the students the art of breaking bad news. So some teaching learning methods in attitude, ethics, and communication are basic, as I mentioned, problem-based learning. So when they learn with problems, they learn the skills of communication, case-based learning, student seminars. When they give seminars, they automatically learn communication skills, debates, storytelling, narratives, role plays, theaters, cinemas, painting, music, and cartoons. Now, these are domains of medical humanities, which is again a topic in itself, which cannot be covered in this short period of time. But then these are very important methods in teaching attitude, ethics, and communication. This is one of the papers which was very interesting. I came across when I was searching for this lecture. So SIR approach to teach and learn attitude, ethics, and communication. S for sensitization, I for immersion, and R for reflection. So you first sensitize your students, then you ask them to immerse themselves, to experience themselves into the module, and then write their reflections. This is how they learn ATCOM skills. How do we assess ATCOM? You ask them to write portfolios, you ask them to write reflections. You can assess ATCOMs in OSPEs and OSCEs. You can do a workplace-based assessment. And the most important is 360-degree feedback or multi-source feedback. In conclusion, This kind of comprehensive approach will create competent doctors in the future who are knowledgeable about the subject with skills to apply it wherever necessary. And it is high time that we stop teaching and assessing the antiquated and pointless tests that are no longer used even at the most remote medical facilities. This shall actually serve the purpose of teaching pathology as the foundation of clinical medicine by bringing the subject of pathology from the classroom benches to the patient bedside. Thank you. And this is His Holiness Dalai Lama, who says that when you talk, you are only repeating what you know, but if you listen, you may learn something new. So we should always teach our students that when we are teaching our communication skills, we should also teach them the art of listening. Thank you very much.
Thank you, Professor Ashitawa Debray, for your wonderful presentation. Over to Professor Kaushik from Bardhaman Medical College for his presentation.
Am I audible?
Yes, you are audible.
Slides visible?
The slides are visible. Slideshow mode, please. Yes.
Good morning, everyone, and thank you, Professor Arunima Chaudhary, for organizing this session on medical education. So I am going to speak on the digital learning tools in medical education. So digital learning tools in medical education. So digital learning tool plays a very important role in medical education in all phases of MBBS curriculum nowadays. Previously, when we were students, we have no idea about digital learning tools. But nowadays, it plays a very important role in medical education in all the phases, not only MBBS, even in the postgraduate and postdoctoral career. So digital learning tools includes teaching and learning that is enabled by the information and communications technology, both inside and outside the classroom. It is not only in the classroom, but outside the classroom. Now, there are so many digital learning tools. As you can see here, when we talk of digital learning tools, we have YouTube, Google, PowerPoint, these are all digital. Zoom that we are using right now also. GSU, Mentimeter, Moodle. There are so many digital learning which are nowadays available. So these are the different digital learning tools. Now, what was before and after the COVID-19 pandemic? So COVID-19 pandemic, it started around the early part from 2020. Everything, the world came to a lockdown. In our country also, it was a lockdown from the middle of the March. But what will happen to medical education? This was our thought. And at that time, there were remarkable advances in the digital technologies in the field of not only medical education, in the field of education as a whole, that we have to use now digital learning tools so that we can maintain the physical distancing. So there was a remarkable advancement, and COVID has taught us really to use these digital learning tools in medical education. The COVID-19 pandemic accelerated the adoption of online learning, forcing educators to adapt quickly. Virtual classrooms, video conferencing, and learning management systems have allowed teachers and students to connect beyond geographical boundaries. Previously, when we didn't use these types of digital learning technologies, there was teacher and student who are in a classroom. There was physically the teacher was present in or is present in the classroom and have their interactions. But now the teacher may be seated somewhere farthest away, not only from this country, maybe he or she is sitting in US and teaching our students. So there is now no geographical boundaries. Even today, the conference is being held in Islamabad, and I am speaking here from Kolkata. So it's beyond geographical boundaries. This is what generally COVID taught us. Next is enhanced learning experience. This is the importance of digital learning. Other importance are accessibility and flexibility, improved knowledge retention. So what is enhanced learning experience? The digital tools offer interactive and engaging learning experiences for medical students, making complex concepts easier to understand. Accessibility and flexibility. Online resources allow students to access educational materials anytime, anywhere, promoting the flexibility and self-paced learning. The students may be busy right now, he or she goes home or in the hostel, sit and relax, then again go back to the educational materials. Because it is always available 24/7, anytime, anywhere. Improved knowledge retention. Studies have shown that digital learning tools aid in better retention of medical knowledge, interactive simulations, and virtual patient scenarios. So, as we can see that we retain more when we can see these in front of our eyes. So there is better retention of medical knowledge by interactive simulations. We may not have all the patients right now, but we can have some simulations too. New trends in medical education after pandemic is the teaching and learning. Not only teaching and learning, there are newer methods of online assessment, tools like Google Forms. In the COVID times, we used to send timed Google Form to our students. They were given a certain time to answer the questions, and after the answer, the question, it was automatically assessed or maybe assessed by some of our faculty members. So these were the newer online assessment tools. We have learning through YouTube tutorial videos. There's growing educational resources for medical learners and educators. There are digital books. What are digital books? E-books. E-books are previously also available as textbooks, journals. See, there are so many e-books which are right now available, like Gray's Anatomy, Robert's Pathology, Thompson and Thompson Genetics, Beyond Goddess Epidemiology. There are so many e-books which are available. You may not have the physical copy, but you can have the e-books, buy and download it onto your laptop, on your mobile, and you can go through it. There are online videos, mainly through YouTube's, like consider some invited lectures on the YouTubes which are available on Timothy Henry's external fighters. We have so many other lectures which are available on the YouTubes nowadays. There are several websites. The websites which are related to medical education. The websites include medical students, Mayo Clinic. It offers a huge knowledge in this field. Medscape, Stanford University, Radiopedia, Up to Date, Osmosis. These are the various websites which are available nowadays for the medical students. See, if you want to know the thyroid disease clinic at Mayo Clinic in Minnesota, you have all the important documents which are put over here, to see the thyroid eye disease. The medical students, the undergraduates, maybe the postgraduates also may go through these materials available over the net. Now we come to another important aspect, that is computer assisted learning. which is an effective way of teaching and learning in medical education. What does it do? It provides the student with unlimited time. So if you are given unlimited time, the student will definitely reach his or her mastery in that field, because he can go through it again and again through this computer assisted learning. The computer is never judgmental if the student makes a mistake. The teacher is may be judgmental, he may scold, he may not like it, but the computer is never a judgmental. And the topic can be repeated frequently without the computer becoming impatient. If the faculty or facilitator is repeatedly asked on the same topic, he may feel something impatient and say that I have explained, go through your book, but the computer is never impatient. There are several online platforms in the field of medical education where there is a teacher-student interaction, like Google Classroom. It's a classroom designed by Google where you can put your messages, you can put your teaching learning materials, you can have your question answer sessions, you can have Google Forms attached to it. There may be timed, there may be submission time. So it's an initiative by Google, that is a Google Classroom. The Google Meet, that is direct interaction with the medical students over the net, and Zoom, which we are right now using. So in Google Classroom is where the teaching and learning come together. It helps educators create an engaging learning experience. They can personalize, manage, and measure. Measure is you can assess. Part of Google Workspace for education, it empowers educators, enhances the impact, and prepares students in the future. So this is a Google Classroom for school students or college students, in the right side. We can have it, we had it actually for the medical students in our COVID days. Now coming on to the learning resource management system, which is an important digital tool in the field of medical education. It's a software application or web-based technology used to plan, implement, and assess a specific learning process. It's a web-based technology which you can use to plan, and use to implement and assess a specific learning process. It is used for e-learning practices, and in its most common form, it consists of two elements. That's a server that performs the best functionality and a user interface. We do not see the server in front of us, we see the user interface that is operated by the instructors, students, and administrators. The server is in the back end. So it has two parts, server and user interface. So this is the learning resource management system. We have our Moodle. It's a Moodle community where we can interact with the students through Moodle. The place to get support, ask and answer questions, and to contribute to the open source learning platform. So it's an open source learning platform is the Moodle, and it's a learning management system, a Moodle LMS. Now coming on to other aspects like podcasts. It is used for podcasting platform to discuss and disseminate information about treating patients. In the clinical aspect, when a facilitator treats patients, he can broadcast it or podcast it. Podcasts in critical care, emergency medicine, internal medicine, and others have been involved in educating clinicians. With the increased use of smartphone and social media, podcasts have been recognized as a means to rapidly disseminate public health information. It's a very important tool in the field of public health. We can disseminate public health information by using these podcasts. The more newer aspects, that's the augmented reality. It's a relatively new technology that allows for digitally generated 3D representations or three-dimensional representations to be integrated with real environmental stimuli. So this is an augmented reality. We create a 3D or three-dimensional representation in a real environment. So what are the main goals of augmented reality-based learning? I've taken it from a journal. It is to simplify the delivery of complex information, advance the communication skills. As in the last lecture we have heard, that communication skills is not only important for the clinicians, but also for all the different disciplines in the field of medical education. Everyone has to have a good communication skill. Enhance the sense of reality. To facilitate the use of large data sets. To integrate virtual objects into physical space. To enrich comprehension of medical imaging. It's also one of the most important aspects nowadays. Have the comprehension of medical imaging through augmented reality and AI. Now we come to virtual reality. It produces a virtual manifestation of the real world, and it has been shown to be as useful as a digital medical education modality. So it is a virtual manifestation of the real world. See, this is virtual reality in front of you. So, how can we balance it between the traditional teaching and e-learning? So we can have something like blended learning, which is a combination of both the traditional forms of classroom learning with the elements of e-learning. We keep e-learning side by side, we keep classroom learning side by side. So it's a blended learning. It's a combination of traditional forms of classroom learning with the elements of e-learning, which uses tools of information technologies such as computer graphics, audio and video, interactive elements, etc. So we blend both types of learning. There is some human aspect which is always required for medical students. That is why blended learning is one of the most important modality nowadays. We use both the human resource, we use both technological resource. The human gives the motivation, personalization, direct feedback then and there, fluency and listening, relevance, and overall the discipline. Whereas the technology, that is digital learning, it gives the mobility, structure, tracking and control, self-study, reduced cost, and global reach. So if we blend together, it becomes blended learning. Now, when I conclude, it's a take-home message that is integrating digital tools may require specialized technical support and infrastructure, ensure seamless operation and user satisfaction. Educators may need training effectively, utilize digital tools of ongoing support is essential to address any technical issues that may arise. Advancements in artificial intelligence and adaptive learning algorithms are paving the way for personalized learning experiences tailored to individual student needs. So these are the take-home messages from these digital learning tools in medical education. I may end up with something like this. If you change nothing, nothing will change. So if we are here to change from the traditional teaching learning methods to newer teaching learning methods, we have to change. So if we can change, everything will change. But if we want to change nothing, nothing will change. So this is Burdwan Medical College and Hospital, located in the eastern part of India in West Bengal, where you work. And thank you all for your patient hearing. Thank you.
Thank you, Professor Kaushik, for your wonderful presentation. Over to Dr. Kiran Kumar Ganji from Saudi Arabia.
Thank you, madam. Am I audible?
Yes, sir.
Yeah, understood. Is my screen visible, madam?
Screen is visible. You can start, sir.
A very good morning to all the participants, and I would like to thank Prof. Arinuma Madam for providing me this opportunity and all the organizers for providing this facility or the platform to convey this session. So today I'll be speaking about the topic of mentoring and reverse mentoring in medical education. I will be focusing more about reverse mentoring in medical education. I'm Dr. Kiran Kumar Ganji. I'm an assistant professor working in College of Dentistry, Jauf University, Saudi Arabia. Now, currently, traditionally, when we see mentoring is being done in day-to-day practice, every faculty in every college or every student is being involved in this phase of mentoring. So this mentoring can occur in traditionally fashion that when a mentor is considered as an experienced person who guides the mentee in developing his knowledge or skills required for the professional development. So this is what routine traditional process which has been done. And this can occur at a different classical models or a classical cascades which occur during this phase. It can occur in a fashion of group mentoring, where a leader is trying to mentor a group of students or a group of learners. It can occur in a phase of network mentoring, wherein a mentoring is being done for a different groups to interact among the groups with a unique purpose, or they have some objective, or their aim is to have to achieve some goals. There is spot mentoring. This is what usually happens in medical education. Like when you go for clinical encounters, or when you supervise any students in your clinics, you do spot mentoring. So, and finally, now what, as we had in the previous sessions, like digital tools have come up. So we have something called as virtual mentoring also. So with this basic background, I'll not much go into mentoring aspect, but I'll go more with respect to reverse mentoring. Now this mentoring ship, it basically has major things which it relies on. To be specific, we need to understand that this mentorship is a relationship. The word mentorship itself will tell you about there is some continuity of relationship which has to build upon. And that building will occur when there is reciprocity about mentor and mentor relationship. If this reciprocity is not being built upon, then the mentorship is not being established, or it will not rely, or it will not continue at all. So this process is very important in building up the mentorship. Now there are some developmental benefits which it relies on, because mentee is coming for the purpose of education, for the purpose of his career build-up, and he needs certain motivation, certain support with respect to from the mentor for his learning activities. So that also has a major role in relying in maintaining the mentorship. And of course, not but the least, that this mentorship also relies on the consistent communication that has to go on for a period of time until he or she completes the program for which he is enrolled. Then that communication which is being established during the entire phase of the program is also plays a major role in successful completion of the mentorship. Okay. Now let's go to the reverse mentoring. Now, traditional mentorship is nothing but what a mentor is the highly professional or highly qualified faculty is trying to train the mentee who is less experienced or less knowledgeable. But when we go for reverse mentoring, this is what something which is not occurring in traditional process. It is something reverse of what is called as mentoring, wherein the mentee is totally the reversal of the traditional roles. where a mentor who was supposed to act as a mentor or the experienced person is acting as a mentee, and a mentee who is supposed to act as a mentee who is less experienced is acting as a mentor. So this hierarchy of thing which is getting reversed is nothing but explained in case of reverse mentoring. As truly said and crucially outlined by Zuckerman's study, who told that for a reverse mentoring, they both aim for the development of mentee and mentors. So see this beauty of this reverse mentoring. Here, it is not only the mentee who is getting a development, but even the mentor is also getting the development, or he's also getting benefit out of this reverse mentoring. So it is both ends, it's a two-way process where both are benefited out of this mentoring. Now we'll understand what are the characteristics of the reverse mentoring. As it's truly said that more experienced specialists are mentored by a less experienced specialist. And in this phase, there is a junior or mid-career mentors are involved with this process of reverse mentoring. This is one of the characteristic of reverse mentoring, and with the help of present and future technology. In near future, you might come up with this. So there is a more experienced mentor learn from more experienced specialist and who have extensive knowledge. And no doubt they have a capacity to narrow up the knowledge or the gap that has existed because of the generation which we have seen. We have seen generation X, Y, and Z, and this has a major influence which has come up with because of the technological advancement. What our teachers were well acquainted with the technology, we know that our students, current students, are more well versed with the technology. So this generation gap which has occurred and generation has gained the advantage of the technology has built upon this reverse mentoring characteristics. There are certain ways that this characteristic feature of this reverse mentoring plays a two-way learning process wherein a mentor and a mentee both are getting benefited from each other. At the same time, professional skills of mentoring are also developed by the more junior mentor. Professional skills are also has been expressed. Now we'll compare. It becomes wise for us to compare, like when I was speaking more about traditional reverse mentoring, it becomes very wise enough for us to compare this with the traditional mentoring. And this can be easily done with three characteristics. One is the length of mentorship relationship, how long it exists, who mentors who, and then finally, the subject areas and the nature of the guidance. In case of traditional mentoring, the length of mentorship is longitudinal. Like it occurs the entire range or the entire duration of the program wherein a mentor and a mentee are involved in the fashion of teaching and learning process. So this is a longitudinal. But in case of reverse mentoring, it is of short duration only, and it is of short span. It can occur at any point of time, and later on, it can again come back to traditional phase of learning. So it is a specific driven and a objective driven. At one point of time, the mentor might not be well aware of the concept which a mentee is trying to bring it up. So that phase only is called as reverse mentoring, and that's why we characterize it as a short duration. Now here we coming to the second point: who mentors who? In case of traditional mentoring, a more experienced specialist mentors the less experienced specialist. But in case of reverse mentoring, it is a less experienced specialist mentors the more experienced specialist, and that is for a specific point of time or a specific objective only. If you go to the subject areas, we have a broader and holistic approach for mentoring, especially for this professionalism, for research oriented works, or in case of work and life balance aspect. And more in related to medical education, we deal with the professionalism aspect. And in case of traditional, when we see the subjects, it mentor fulfills the nurturing role as a parent, where he tries to guide a student to attain his goals. When you go for reverse mentoring, The mentee can provide nurturing role behavior to eliminate. It's at one point of time where a mentor can be acting as a emulator to change his role. So that a short period it can be subject. And if it is often targeted to improve specific knowledge, especially in case of e-learning, like e-medicine, like use of apps, or to how to build up new technology to enhance the patient care. So that can be addressed with this aspect of reverse mentoring. So after comparing this traditional and reverse mentoring, let's go to the attributes and behavior of effective mentoring in reverse mentoring. What an attributes and behavior a mentor should have in case of reverse mentoring? The main aspect is attribute is the patience is required in new teaching concepts. They should be having generous with their time spent on this process. No doubt they should be very enthusiastic in the area they need to learn. If they are lacking in the knowledge, they should be responsive enough to need to understand the needs of the mentee, because he is trying to explain something. That means we should be responsible to understand this aspect. Most important is he should be honest and professional in their feedback. Yes, he should understand at one point of time I may not be aware as a mentor, may not be aware of what concept the mentee is trying to behavior to bring it up, and I should be having a patience to understand it. He should be clear and effective communication between them. They should have the values with respect to ongoing going learning process which is occurring there. And finally, the willingness to share the knowledge and experience, or to gain the knowledge and experience from the mentee, should be there. When you go for behavioral aspect, yes, behavioral comes with more of respect with respect to acknowledgement what the mentee is trying to bring up with the concept. He should understand the mentee may have limited time and extensive responsibilities, but at one point of time, he's trying to get some aspect which mentor might not know. He should also encourage the formation of joint learning objectives, because both mentor and mentee are working for the mission and vision of the program. So they have certain joint objectives and goals to be achieved. So they need to understand this aspect. So they work together. They provide comfortable learning environment which has to be occurred. And finally, they actively listen to the needs of the mentee to improve the cross-generational communication. This is also one of the important aspects which had to be in a behavior modification has to be done in case of mentors for reverse mentoring. We'll go to the attributes and behavior of effective mentees. If you go to the attributes and behavior of mentees, yes, attributes with respect to them, they should be open to learning new concept. Yes, they should be in a position to understand that I should know what is the new concept there, and ability to taught by those younger. Remember that you are a member. This egoistic aspect has to be totally kept aside, so that he is a mentee, he is trying to teach me, that should not be there. At times, a mentee can become a mentor. Then ability to receive honest feedback, that is was is aspect is to be taken there. Proactive in identifying the special needs. Yes, at one point of time, the situation comes into there that we need to be proactive, and the communication skill. If you go to the behavior aspect, you need to show the respect for the skills of the mentor. Yes, we need to also understand that he is a mentor. At times, you might be acting as a mentor, being a mentee, you are acting as a mentor, but you should keep in mind that he's always a mentor for me. You should also need to articulate their needs clearly to the mentor, and effective based learning also additional changes has to be done. So these were the attitudes with respect to mentee. Now we'll understand what are the potential benefits we get out of this reverse mentor. If you see, literature has proved that with this process of reverse mentoring, there is increased job satisfaction with respect to mentor. They understand new learning concepts as they gain new professional skills. They access to the links to the wider network. Professional critical thinking aspect has to be is being enhanced to those in this of leadership roles. They have practice in providing honest feedback to senior colleagues. They provide greater opportunities also to the include that enhances the research outcome of the program. They have opportunity to role model their lead from their leaders with qualities to admire. So these are some professional benefits which the mentors get out of their reverse mentoring. What about the mentees? What benefits they gain out of this? They have the improved social capital of organization. Yes, they have renewed enthusiasm. This will come at one point of time when a mentee is acting as a mentor. The enthusiasm and the energy level to read, to enhance their learning capabilities will increase. So that will get overall motivation for the students to get enhanced learning. They get the greater insight into the workplace environment. Workplace environment will get more friendly enough for the mentees. They get more motivated into this. They also provides the opportunity for the junior specialists to get a wider network, and which was otherwise becomes very difficult if this process would have been not established. And finally, they gain the attainment of the new learning knowledge and skills at the workplace environments. So with this, we conclude that in a challenging healthcare and medical education landscape, the role of junior colleague as a mentor will increase with this. And at the same time, particularly with the advent of the concepts such as electronic health data and online platforms, and improved interaction within the workplace and across disciplines are emphasized. We also should know that more senior colleagues can benefit from their junior colleagues by enhanced understanding these concepts and involvement in the new research. That's there. Thank you for your patient listening. Thank you.
Thank you, Dr. Kiran, for your wonderful presentation. Over to Professor Kamal Singh from Haryana, India, for his presentation. Dr. Kamal, you are muted. Please unmute yourself.
Is it visible, ma'am?
Yes. It is visible, but there is a black box in the upper part.
Now it's clear, I think.
In the upper part, there is one black box. It is in slide share mode. You can start.
Okay. So I thank you, the APAN team and Dr. Arunima for providing me the opportunity, and Dr. Aarti for helping me for preparation of the topic. Professor Kaushik has already sensitized you all for some part of my topic, that is the current trends in medical education, innovations and future directions. Why to stay updated? This is the first most question must know. Staying updated ensures that educators and practitioners are aware of the latest research, treatments, and best practices. Up-to-date curricula ensure that medical students receive the most current information, preparing them better for the real-world practice. What is the importance of staying updated? That is for the patient's safety and professional growth. Impact on medical education and healthcare delivery, that is the integrating current trends and technologies in medical education makes learning more engaging and effective. Staying updated promotes collaboration across different healthcare disciplines, improving team-based care. The patient-centered care is there. Global health preparedness and to address the health issues on an international scale. Adaptability to new protocols and technologies, maintaining high standards of care. So what are the changing trends in curriculum development, faculty development, teaching and learning, clinical training, student selection, student assessment, student support, leadership and management. So new trends in curriculum development, they are defined by organization of contents. For example, integrated organ-based curriculum, integrated clinical presentation or task-based curriculum, defined by teaching or learning methods, that is the problem-based curriculum, case-based curriculum, defined by learning objectives, competency or outcome-based curriculum, defined by social responsibilities, community-oriented curriculum. But why we need this? Because as Indian medical graduate, is a clinician, communicator, leader, professional, and lifelong learner. So, what are the current challenges in the medical education? These are the resource constraints, limited faculty time, funding, and access to advanced technology hinder the delivery of quality education. Increased seats, that has teacher-student ratio, increased seats in number per colleges, and curricular adaptation, keeping curricula relevant amidst rapid advancements in medical science and technology. Other are the wellness and burnout, addressing the student and faculty burnout and mental health issues, diversity and inclusion, technology integration barriers. So these are the challenges. What are the possible solutions? Possible solutions to current challenges are artificial intelligence and technology-based innovations and human intelligence-based innovations. So what are different artificial intelligence and technology-based innovations? That is adaptive learning platforms, virtual dissection and simulations, personalized learning platform, automated assessment and feedback, natural language processing for interactive learning, augmented related and virtual reality. Human intelligence-based innovations are the innovative pedagogical methods, mentorship and personalized guidance, enhanced hands-on dissection, labs, models, prosections, workshops and practical sessions, interprofessional education. So, what are the applications of innovation AI in medical education? That is the personalized learning platforms, virtual simulations, and adaptive learning algorithms. What are different personalized learning platforms? They are complete anatomy by 3D 4 medical, visible body, anatomy zone, biodigital human, CanHub, primal pictures, and Lecturio. So as you see, this is the video. You have a better visualization of different structures by seeing these videos. Another, the anatomy. Nowadays, it is very popular among different colleges. This can have the 3D visualization of the cadavers. So this is teaching without cadavers. Another is CanHub. What are other AI-powered tutoring systems? They are Anatomy Tutor, Osmosis, Memorang, Quantum, Picmonic, Sketchy Medical, and Figure One. These are the different AI-powered tutoring systems. So, medical education is being empowered by the AI that provides the real-time feedback, AI-driven assessments, and interactive learning modules. Now coming to the virtual reality and augmented reality. They provide immersive and interactive learning experiences to the learner. Virtual reality headsets, immersive 3D environments for exploring anatomical structures. Example is Oculus Rift or HTC Vive. Various available platforms are the OSO VR that specializes in surgical training simulations. Complete Anatomy provide detailed 3D model of the human body. Touch Surgery offers VR surgical simulations and training modules to practice surgical procedures and techniques. EcoPixel offers VR solution for medical imaging to visualize and interact with medical scans in 3D space. Mersion provides VR simulations for training in communication skills and interpersonal interactions. Proximi focuses on telemedicine and remote consultations using VR technology. So these are the different platforms that using VR for learning the human body and the applications for the different surgical procedures and other departments. And there are some online platforms and courses are also available. That is MOOC platform. For example, is Coursera, virtual labs, interactive web-based lab simulations. Duke University, one of the university that is also offering the medical neuroscience courses through online or MOOC platforms. Other technological innovations are the learning mobile apps, providing detailed 3D models and quizzes. For example, is Essential Anatomy, Human Anatomy Atlas. And these are the different technological innovations you can have in your mobile to have a handy look for this. Ethical considerations in AI are also there. That is mainly the data privacy, that is algorithm bias and transparency in decision making. So what are the pros and cons of AI in education? Pros are it has improved student engagement and motivation, enhanced student performance, it is cost-effective learning, and continuous evaluation and improvement in the long run. But what are the cons? Threat to the teacher's job security, dehumanized learning experience, costly to implement for teachers, and dependence on the technology. These are the cons. So the question arises, can the student rely only on AI for learning the medical curriculum? Answer is no. So what to be done? The current trends in which human intelligence is involved are the active learning strategies through innovative pedagogical methods. That is the project-based learning, flipped learning, CBL and PBL, case-based and problem-based learning. Collaborative learning are the peer teaching, interprofessional education, peer review and feedback, personalized and reflective learning, mentorship and personalized guidance, continuous development and integrated curriculum, hands-on and practical experience, enhanced hands-on dissection labs, models or pro-section, workshops and practical sessions. So this is the old traditional classroom. What really happens there, as we all know, there are number of students is too high and there is a teacher-oriented approach only, and information is very less reached up to the students. But we can't dump the lecture theaters also. So what is the solution for that? We need to develop active learning strategies. That is one of the strategies, flipped classroom, in which students come prepared, already given topic, and they come up with their problems and they discuss there, and teacher acts as a facilitator to help out the problems unsolved by the students. Another is the case-based learning. That is the realistic clinical cases to teach anatomical concepts. These cases provide context and relevance, help the student to apply the theoretical knowledge to the practical real-world scenarios. Another is problem-based learning. There are 6-step process of problem-based learning. That is, firstly, we define the problem. Then the solution criteria is defined. Then solution research is done. Then we pick up a solution. Then create a run and inspect the solution. And we'll get the reflections on the solution. Another method is project-based learning, the application of the knowledge in the real-world context by providing any project to the students and they come up with their solutions. Example is activity given to the student, that is design a fitness program targeting specific group of muscle. Objective, link the muscular system to fitness to emphasize the importance of exercise. And components, identify exercises, create workout routine, explain muscle effects, emphasizes proper form and safety. So once it is done, the student may know what is the action of that particular muscle. Another is the peer learning that involves students in teaching and learning from each other in a collaborative environment. Enhances understanding, retention, and critical thinking. Foster communication and leadership skill. Collaborative drawing and mapping can also be helpful. That is making some map by group project to the map out anatomical systems on a large chart or digital platform, like pathways diagrams, peer-assisted dissection, and enhanced memory and understanding through visual and kinesthetic learning. This picture depicts the menstrual cycle, and lastly, one cycle goes with the baby and another cycle goes without the baby happily. So these are the charts. They can be very effective for learning also. Another innovation in practical classes is coloring the dissected structures. artery with red, nerves with yellow, and veins with blue. So these are the different colors used for the different type of structures, and this will enhance the education. Another is learning anatomy with model making along with the dissection. So models can be made, and this is lumbar plexus made with the wires of different colors. And so these can show the roots and different nerves that can be studied in practical classes with models. Another is the innovation is the body painting. Some colleges organizes such kind of events also, so as to enhance the education among the students. One of the way or innovative method already published in a journal. So this is innovative method of teaching histology. These are the different flags of histology slides displayed in the classroom or histology lab on the walls, so that students can have a repeated look and they will memorize and learn for future. Another way is gamification in learning. That is, examples of gamified tools and research resources are Anatomy Arcade, Proforce Brain Games, Teach Me Anatomy, the Anatomy Game, the Skeletal System Game. So these are interesting games. Apps can be used in mobiles also. So overall, what we want to achieve with innovations, that is for the helping in the better learning. Customized paths based on individual needs and preferences, adaptive content to match learner proficiency, targeted feedback on areas for improvement, aiding skill development, engagement and flexibility for study options at learners' convenience, support for diverse learners, accommodating various learning styles, abilities, and backgrounds. But we are all still superior, a human touch, nurturing creativity and emotional intelligence to thrive in an AI-driven world. So while AI can provide personalized learning experience to some extent, it may not match the flexibility and intuition of human teachers. Complexity of learning, AI can assist with content delivery and assessment. It may struggle with higher order cognitive tasks. Social interaction, AI can facilitate online discussion and simulations. It may not fully replicate the richness of face-to-face interaction. Teachers serve as a role model and guide, imparting not just academic knowledge, but also ethical values and moral principles. AI lacks moral agency and may struggle with non-ethical dilemmas. The future of medical education lies in fusion of innovation and creativity. By embracing new technologies and teaching methods, we can create a more dynamic and effective learning environment that inspires the next generation of healthcare professionals. So, embrace innovation, but never forget the wisdom of tradition. Thank you.
Thank you, Dr. Kamal, for your wonderful presentation. With this, we come to an end of our session, Medical Education. Thank you, APAN Group, for giving us this opportunity to join this session. Thank you, everybody.
Thank you,
Thank you so much, ma'am.
Thank you.